Okay, let's get started. It's 2:02. We've got over 100 participants here. We're going to be flipping our agenda items. First thing we want to do, I'm going to let Lynn establish that we have a quorum, and if we can vote on the meeting minutes for our last meeting.
Good afternoon, everybody. So I know myself and Tracy's on, and I saw Kelly Roker and Ashley. Did Kendra, I believe, was going to be out teaching. Is that correct?
Yes, and she's got I can't remember, but she's got somebody who's reporting for her, and I just saw that yesterday.
It's me, Julie Freeman. I'm here.
Oh, okay.
Thank you.
Thank you, Julie. And Kelly Bond's not going to be here as well, and I believe Colleen was going to report out for her. Is that correct?
Yes, either Colleen and or Gina.
That's right, Jean. So it looks like
I'm on.
Crystal Smith. Crystal, are you on?
You hear me? I'm on.
Yes, thank you. So it looks like we have representation from everyone. So I do believe we have a quorum. So was everybody able to review the minutes that were sent out from our November meeting? And if so, can we get a motion to approve?
This is Julie Freeman. I'll make a motion.
Thank you, Julie. Do we have a second?
I'll second.
Crystal, thank you. Any discussion? All right. Cricket census, I guess we'll say that it's passed with no objections. Does anyone have is anybody new, first time coming to this meeting, or do they have someone new with them they would like to introduce to us?
Hello, this is Chelsea Carter and Heather Jones from South Georgia. We're with SGMC Health. I'm a new PI coordinator, and Heather is the injury prevention coordinator.
All right. Welcome.
Thank you.
Hi, I'm Tamara Patterson. I'm with Piedmont in Columbus, and I'm the new trauma registrar.
Welcome.
Thank you.
Hey, I'm Garrett Polson. I'm the interim trauma program manager here for Piedmont Walton. Karen Hust is retired, so this will be my first meeting.
Thank you for joining, Garrett.
Hey, this is Kristen Gentry. I'm the new trauma program manager at Piedmont Cartersville, and this is also my first meeting.
Oh, well, welcome.
I'd like to remind everybody to use the links in the chat box to record your attendance. If you'll do that, there'll be a QR code again at the end of the meeting to also do that. So if there's a couple of you on a computer, you each need to do that attendance. And again, do that for Gabby. We've got almost 120 people on this call, so it's kind of hard for her to keep up with chat box attendance, and we're trying to be a little automated and fancy dancy. So, but welcome to all the new people. And I appreciate, I believe it was Kristen that sent me an email, reached out about some copies or examples of things, and I will get back to you. I'm glad to be here at the meeting. As most of you know, I had back surgery in December, and now this is my third week back at work. I had 1,300 emails when I came back. I'm down to 800, but I still have a few to go through. So I do have good intentions of returning everybody's responses or emails. But if you need me in the meantime, please just send another email or text me. And I appreciate Lynn joining us. We're going to flip the agenda a little bit, do what we normally do at the end, which is go over some of the new standards for the book. Lynn has got another commitment, so she's going to have to leave. She can attend by phone, but won't be able to speak toward the end of the meeting. And so we're going to go through the standards related to radiology or medical imaging. Lynn, I can't remember who we said was going to do which one. Do you remember?
Yes, you had the first three. I was
Okay.
doing the last two.
Thank you. Okay. So the first one is medical imaging 3.5, and this is a type 1 standard. I like to be positive and say not deficiency. But again, reminder, if you get a type 1 standard, you miss that type 1 standard, that just is, that puts you dead in the water. They're saying this is so important that it has to be a type, you have to have this and you have to meet it. So if you miss a type 1, the survey's over. You've missed your survey. Otherwise, in the type 2 standards, you can miss up to 3 and still be verified, but maybe with a caveat of a revisit or report or whatever they deem is necessary, depending on what your deficiencies are. But in this standard, they say the applicable levels. So again, when they say L1, L2, L3, that means it's trauma center levels 1, 2, and 3, or pediatric trauma centers levels 1 and 2. So it applies to all these. And it's saying in the definition now, it says at level 1 and 2 trauma centers, the following services must be available 24 hours per day and be accessible for patient care within the time intervals specified. And so they list, just regular radiology, CT, point of care ultrasound, interventional, so you've got your time frames of being able to get there. And then they define what is that time frame for a level 3 trauma center and the services. So if you look down a little bit further down at the bottom of this standard, it says accessible for patient care implies that the necessary human resources and equipment are available within the time frame specified. And it refers to the time between initial request and the start of the procedure. It does not mean that every test has to be completed within this interval, but so more or less your average or your median, you're hitting these marks as far as your turnaround time. And then if you go down just a little bit further, you'll see measures of a compliance. It'll say equipment evaluated during the survey process, policies and procedures. Now, one of the things is when you have a survey, a lot of times they're going to say they're going to look at it at the site visit, but things they typically will look for is, again, your policies and procedures talking about availability. So I'm a level 1. We have CT techs at our facility 24/7. Whereas MRI, we have to call them back in. So we look at their callback times. Are they, and how does the hospital define if we call you in for a procedure, how long do they have to come back in? So we kind of say, well, how many times do we have to call them back in and how often? And then we report any times where we've got a delay in care, which actually a delay in care or procedure time is also going to come up under your PI, I think your PI plan standard, which I think is 7.2, where they tell you all these different things you have to measure. But the gist of this standard is you need to have this accessible and you've got to be able to prove to us. Now, I do have something that we can share with the team later, and it's a copy of the 22 PRQ. So when they are asking you, what do you have to upload? If they want, say sample schedules for, different departments, or if it's radiology or whatever, then that's going to be in that document as well. And so I just got surveyed last year. My next survey is not due to 26, but we're already working on these standards because they're newer to us. and we want to make sure we have some of this stuff pulled in or we're measuring it correctly. So it's almost like you never have any downtime. You cannot wait until you're, 6 months before your survey and start getting ready. It's like continued readiness. You always have to have things together and to be there. So anyway, that's the first standard we're going to look at about medical imaging. And remember, this is a big one and it's a type 1 deficiency, or it'll stop your survey if you miss it. Next page. So remote access to radiology imaging. So this is talking about, we have to have level 1 and 2 centers, whether it's adult or pediatric centers 1 and 2. You have to have a way to remotely look at your PAC system or your radiology images, and you have to be able to look at it from referring hospitals, so within your catchment area. So in using a term, that's more refers to the equipment or the software, we use PowerShare at our hospital, and I think a lot of hospitals do, but it's always very, very important that when you transfer to other hospitals, you send that information to the outside hospital. So if you're referring, say, if Lynn sends us a patient and they've got a femur fracture, open femur fracture, or an open tib fib, and they've already x-rayed them, they need to go ahead and send it to us, because our radiologist or our trauma residents or whoever's there can go ahead and look at it and be getting ready, whether that's arranging for things. So this is really important. They say measures of compliance are going to be your mechanism for remote access to imaging, but this is really important as far as time to definitive care too. The longer it takes you to send that to your referring hospital, the more you might delay the patient's care, to the point that if it doesn't upload or it doesn't get sent or somebody doesn't know to send it, then we will end up having to rescan or re-x-ray a patient, which slows things down. So for the transfer in facility, which is what I would be as a level 1, I'm looking at, are they sending us those images remotely? And, we get that report from our residents if they're having trouble finding that. But as a lower level center, say a 3 or a 4, 2, 3 or 4, that would be a good thing to look at for those patients that you transfer out. Did we power share? Is there a way that you can find that out? Or, follow up on to make sure, because as people turn over in radiology or in the ED, sometimes they're not aware of the communication that needs to go on to make sure that those images are sent out. And this is just something to make things smoother for the patient in the whole realm of care. Next. And then radiology access. So this is in all trauma centers. So 1, 2, and 3, levels 1, 2, and 3, the pediatrics 1 and 2, and all trauma centers, a radiologist must have access to patient images and be available for imaging interpretation in person or by phone within 30 minutes of request. Every hospital will approach this in different ways. Typically, they're looking at time of request to time of interpretation. And so again, measures of compliance, they're going to evaluate it during the site process review. So they're, as they're walking through the hospital, whether it's virtually or in person, they're going to be asking people different questions. They're also going to look at your policies and your guidelines. They're going to evaluate it when they're looking at those records too. What was the timeliness? Within our system, we actually have a way where they can run reports and say, what's the average turnaround time, or when there's stat stuff. We also have a contract. So after a certain time period when the radiologist is not in-house, we use like a Nighthawk service. So, they're kind of on call, but we actually use our Nighthawk individual radiologists that are credentialed at our hospital. Sometimes you hire the company, sometimes like with our contract, it's specific positions. So then that peer review of their readings is also included in our information too. So this is talking about access. So in other words, you got to show timely access. And again, look at that. That's a type 1. So if you can't prove that, or if there's anything to indicate that you don't have good coverage and you don't have timely access, that's a delay in care. So you go back to one of those metrics that you're looking at for your PI plan, or that's listed for your PI plan in 7.2. So it's a type 1. So these are all of these are important, but we've already hit 2 type 1s with just looking at these 3 standards. Lynn, if you want to go to the next one.
Sure. Okay, so this is a type 2. It's communication of critical imaging results. So this one applies to all trauma centers, adult and pediatrics. And it just says that there must be documentation of any critical findings that was communicated to the trauma team. Lots of times you see that on your radiology report, where, you know, if there's a critical finding, the radiologist will say, you know, contacted Dr. So-and-so, communicated these findings, or we actually have, you know, we're kind of small. So when our radiologist is in-house, sometimes, you know, they'll walk down to the ED and they'll document that as well. And another part of this one is that the final report must reflect the communication with the trauma team, and also any changes between the preliminary and the final interpretations. Again, that should show on the radiology report. It should document all the, you know, date and time and any changes. One way that so the measures of compliance is they evaluate it during a site visit process, but one way that we keep up with this here is during our operations meeting, we have a slide that shows any changes with preliminary change, like number of images that were viewed, had the interpretation change, and our benchmark was that we want less than 2% to have any changes. So we look at that and we track and trend, you know, see if there's any issues with a certain radiologist or any other process changes that we need to do for that. And then the second one kind of goes along with this as well. It's the timely CT scan reporting. So all the CT scans, the final interpretation must occur no later than 12 hours after completion of the scan. So we look at that too. Our radiologist group, they, on this same slide that we report out during our meeting, they have an average turnaround time on our CT scans, and they are responsible for getting that information to us, and we look at that. And we're also, you know, we're small, so we don't have as lot of patients as our 1s and 2s do, or some are 3s. So we actually can look at these, you know, on a daily basis to make sure the turnaround times from radiology is within that 12 hours, which, you know, for us, since we are small, is well below that. But when they come and review, they'll look at the radiology reports as well, but just having that in our operations meetings, that, you know, we can say, well, you know, we look at this and we track and trend to see if there's any, again, we know with certain radiologists or whatever, to see if there's any issues with that. So I'm sure a lot of you have different ways to track this. And if anybody would like to share, you know, with us, you know, send us an email or whatever, and we'll be glad to share that with a group, because sharing is good.
Yes. Does anybody have any questions or comments they want to make about these standards? I think this is it, isn't it?
Yes, that was all.
So Gabby sent this to you in an attachment. So take a look at it. If you've got questions, you know, call some of your peers, or you can email us. We'll be glad to talk to you about it. You know, even talk among PI or whatever. It's good. This is one of the reasons that it's really good too. If you ever had to run stuff out of the registry, you've got that date and time that it's done. But, you know, as you could see when we were looking at those standards, you've got an order time and an actual time that it's done. So I believe in the registry, you have to put down the time of the actual test. somebody from the registry can comment on that. Is that right? Am I remembering that right? So I guess that's a cricket, so I guess it's not wrong.
No, I'm sorry. Can you repeat it again for me?
So when you record a procedure, so you want to record the first CT scan, the first whatever, the time the procedure is done, the time the CT scan is done, that's the time that you're putting in there, not the time that it was ordered, right?
No, I put in the time that it was done.
Correct. Okay. That's what I thought it was, but I couldn't remember. So anyway, thanks, Lynn, and thanks for the feedback from everyone. Liz, you want to get started with your report?
Hey, Tracy, thank you.
Hey.
Great to be see. So 133 people on the call. That's pretty amazing.
Woohoo!
If I can share my screen real quick, I wanted to, I love that you do this review of the standards. I think it really helps everything. It helps everyone, especially with the transition in a book. But to one of the points that you made about, collecting your information, and that you're really kind of on this hamster wheel with your site survey. This is something that I created a long time ago because I was trying to work it through the brains of my leadership that you really, once you have your visit, there's this sort of, desire to like, woo, that's over with now, but you really are just beginning, because if you look at this little chart here, and it's designed to kind of be all the way on the left, you see that's kind of, time zero, or when you have your site visit, and it takes you, 90 days, if you're lucky, to get your report anyway. So you're already into, and most of the time, what you have to work on. So you're kind of creating your initial action planning and that kind of stuff. But, when you think about creating new policies and things like that, and some of you, your processes are probably a little bit more torturous, especially when you're in these big healthcare systems. It takes a while, but you're really on kind of a short runway. You've got about 2 quarters there. You see, you're almost getting into year 1 post your visit before you get, you can get some things implemented. And then you've got to start your data collection, and because you need a year's worth of data. And then next thing you know, you're like already, it's time to submit your PRQ, and your charts need to reflect whatever changes you made. And it's not just about correcting deficiencies, because that had to be done within a year, right? Because even if you have your less than 3 type 2s, you still have to show correction of those. But they want to see that you're fixing your weaknesses as well, because if you have a weakness that keeps cropping up, that's going to turn over into to a deficiency. So since you were talking about that, I thought I would just share that. So there you have it. And then you're so welcome. And then just a couple quick updates for you guys. We're having our commission meeting next week, and so the packet is posted. There's more than enough information than you ever wanted on the goings on of the commission. Gabby does a phenomenal job assembling the packets and the committee reports, and your GCTE report is on there, and all the work that you guys do is reflected. So take a look at all of that. Our meeting is going to be here, where our office is in Madison. It's actually going to be at the James Madison Conference Center. Many of you might have been here for the meeting that was over in the city council room. We had a little location conflict, so we can't be there. So it's actually underneath of the Town 220 restaurant, and we'll have all the meeting information posted on the website. So please check out the website for all the details. If you plan to come, we'd love to see you there. The biggest news I have is that I want to welcome Crystal Shellnut as our trauma system development manager. And Crystal comes from Region 10, as she was the RTAC coordinator there. I think if we were in person, I know Heather Morgan would probably be shooting spitballs at me right now, because I know she's a little angry that we're stealing Crystal from Region 10 as all the other folks are, but it's going to make her so great in this role because she's very familiar with some of the challenges of RTAC. So she's reaching out to all your regional trauma advisory committee coordinators and is going to set up meetings with them. So I hope through the work of your RTAC, soon you will all get to meet and know Crystal. And we really want to make sure with Crystal joining, it's been great. We've kind of looked back at some of the language for both the EMS grants and your trauma center contracts. And we want to make sure that the language is a little bit clearer about the trauma center's role with RTACs, because trauma centers should really be leading the activities of the RTAC. So that's just kind of a little heads up, a preview of what might be coming for your PVP. So, and of course, we always work with you guys on that. So we just want to make it so that the RTACs can be successful. And many of you are already doing really great work, but we know we've got some challenges in some of the regions, and Crystal looks forward to working with you all on that. So, and if you come to the commission meeting, you get to meet Crystal in person. So if you haven't met her yet. And then the legislative session is in full swing. The General Assembly has already had the AFY appropriations hearings, and they're getting close, I think, to a vote on the amended. We're not part of amended money anymore. We don't have to go up and, you know, beg for the balance of our super speeder funds, because with the establishment of the trust fund, our process is a little bit different. We only present for the next fiscal year, so FY25. And I'm shocked that it's only February 8th and that first appropriations hearing is the House. It's going to happen on Tuesday. So we're going up there Tuesday to present that. Included in that will be Dr. Ashley will present that trauma system stabilization plan, the $61 million ask. That's a huge ask. I will say that it has been well socialized across all the leaders. It's been heard by the governor's policy team, the governor's office of planning and budget, the lieutenant governor's office, the top appropriations chairs on both sides, the House and the Senate. You know, Dr. Ashley and Dr. Dunn have done a great job, really, and they had a lot of those meetings before the session even started. So folks are understanding what it's really going to take to, you know, to not just keep all of you who are at trauma centers, keep your trauma centers in the game, and in addition, recruit centers where we really need them the most. So I will keep you guys posted on that. We won't know for sure, but it will be great to get some feedback on Tuesday and then the commission meeting on Thursday. So hopefully, you know, we can share some feedback or what the sentiments are on that. And then I've already given you the meeting information. Let me just check and make sure. While I'm looking at my list, the one thing I'm going to pop a link in here for you all now. You may or may not be aware, but the ACS has just opened the open comment period for the section of the Gray Book standards that has to do with the qualifications of the trauma program manager. And you may or may not know that the Society of Trauma Nurses came out with a position statement on this, that it needs to be a nurse, because a nurse has the specialized knowledge and breadth of experience, et cetera, to really be able to review care across the continuum. That position statement was supported by Trauma Center Association of America. But the ACS is a little reluctant to go out on the limb and say it must be a nurse. So while they have the open comment period, I would encourage you all, you don't have to be ACS verified to go in there and say it. But click on the link and, you know, kind of share your thoughts with them on what you think the requirements should be. I can also send you out the position statement and TCAA's follow-up on that. The concern is that this may impact rural centers where you know, the personnel may be a little slim, and we may have to look at what other options could be. One of the suggestions was to make sort of an alternate pathway like they do for non-board certified physicians. And the ACS didn't really find that palatable at the time, but you know, depending on what the feedback comes from the open comment period, you know, we may be able to make a little move in that direction. So I just kind of wanted to give you guys a heads up about that open comment period, and I'll wrap it up with that, and happy to take any questions, comments. And I see Heather's sending spitballs my way. Thank you, Heather.
Hey Liz, it's Heather. Yes, I'm sending spitballs your way, but I would be remiss if I did not say that, yes, I'm very sad that we're losing Crystal, but she is absolutely awesome. And I'm excited that everyone in the state will get to experience her excellence, and not just us in Region 10, but I am still just a little bitter. So I just need a little time.
Okay, we'll give you some recovery time, Heather. But yes, you're right. Crystal is going to be amazing. She has a great background in emergency preparedness and EMS education. So it fits so nicely. And I'm glad you're willing to share her. Thank you.
And Liz, if I could remind you to put that, remind everybody where they can find the Georgia Trauma Commission reports and also the STN stakeholder feedback that you just stuck in there. So yes, you know, we have a great group that is very participatory and wants to know what's going on. And so when we get the opportunity to make our voices heard, like with this meeting or our subcommittee meetings or online with comments like this, we need to take that opportunity and step up and do that. You know, we might not agree on everything, but I think it's very important that you make your opinions heard and that we listen to one another. So thanks for that report, Liz. Okay. Marie and April?
Good afternoon, everyone. I'm Marie Probst with the Office of EMS and Trauma, and welcome to the new folks on the call. We'll be meeting you in person, hopefully very soon. So my first update is about the downloads. We've received all of the center's downloads except 2, so that's very encouraging, into the Image Trend Patient Registry Central site. And we are waiting on 2 more OTCPEs from the centers and 1 from the burn center. We are preparing aggregate burn data into a PowerPoint presentation similar to what we did in 2018, 2019. So more to come on that. And regarding the 2024 ESOV5 update, I'll let Gina give you the specifics of that. But I just want to remind everyone, when you're doing your imports into the Image Trend Patient Registry for the Office of EMS and Trauma, to remember that the annual link, the year specific link that you're going to click on, must correlate with the set of records that you're importing. For example, you want to use the 2023 import link in the Image Trend site for your 2023 records coming out of your V5. Once the 24 update goes out in your registry, you'll be able to do the 2024 download, but we're not going to open the 2024 import link until we have closed out the 2023 data set and received all the data. So you'll hear this little blurb many times, I'm sure, before you're able to begin importing your 2024 data, which is actually due in June. So thank you. I'll turn it over to April.
Thank you, Marie. Good afternoon, everybody. I hope everybody's had a good week. I hope everybody has a great weekend. Tomorrow is Friday. I could not be more excited about anything. So for those of you that don't know or haven't met yet or had any interactions with, Stacy Smith is the trauma coordinator for the state. She is on this call. I'm going to actually let her give the updates of things that she and Marie, have been working on. If you have not met her and you plan to attend the commission meeting next week, she and I both will be there in person. The one thing I do want to touch on is that since we have received the 2023 data, we are planning to dive into North Georgia's data since they did participate in the armband project. So we'll be looking pretty closely at how well that project went, if it was fruitful or not, should we continue it or not. So more to come. I know that's been a long time coming. And I appreciate everybody who's been involved in that project. And we do have all the data now, and we plan to start looking at it. But I'm gonna let Stacy do the rest of our updates. Stacy, are you on the call?
Hello. Hello, everybody. My name is Stacy. I am the trauma coordinator for the Office of EMS and Trauma. I have emailed a few of you. I have met a few of you, but I look forward to eventually meeting all of you as we go through our visits to the hospitals. And then I just want to say thank you for all the ones that have reached out and have also helped me with this new role. The first update I have is for data validation visits. So Marie Probst is scheduling some data validation visits with Gina. So they will be going, making a schedule and contacting your facility if they're going to visit and go through your data. And if you have any questions, you can reach out to Marie. The second update is our trauma team is working on level 4s this year. We want to get all the level 4s hopefully back on track and back on schedule. And we will be doing consult visits and site designation visits this year with level 4s. And then our office is excited that we just published our Georgia Trauma Report. It's our 2022 annual report, and we're hoping to continue to do this annually. It is on our website, and we do have, we're going to print some copies and have those around and distribute them out as well. And that's all I have for our office as of now.
Stacy, for those that aren't going to be able to be at the meeting in person next week, can you tell them where they can find that on the internet if they want to look at that report?
It's on our the DPH website.
Stacy, do you mind just dropping that link in the chat for everybody?
Yeah, sounds good.
To the page where they can access, Tracy, we just recently published the 2021 and then the 2022 right behind it. So both of those are available on our website.
Right. And thank you for mentioning that, April. Just because we constantly have new people coming, I like to remind everybody, or, you know, for those of us that kind of have moldy brains like me, Dr. Ashley, you know, wanted me to do a brain dump before I had surgery because he said, what if you stroke out on the table? You know, which is very encouraging before you have surgery. But, you know, so we need to share this data with one another and just know that there's stuff out there. So.
Absolutely. For those that don't know too, we are publishing and printing our Office of EMS annual report. It's the first one in, I think, a decade. It's not specific to trauma, but it does have some trauma data in it. It's the data that's within the trauma annual report, but it is an annual report for all of the Office of EMS. So regional data as well as state EMS data, and then all of the different systems of care data. So as soon as that drops, we can send that out in the GCTE contact list so that everybody can take a look at that as well.
Thanks, April.
Mm-hmm.
Okay, Cheryl.
Good afternoon, everybody. I want to just provide you all with a little bit of an update on what's been going on with the Rural Continuing Education Program Initiative, We have had a lot of just great success in the first year of the program, which actually concludes at the end of next month. For the first year, our goal was to have 12 courses, but if nothing changes, we will have coordinated 17 courses simply because of the demand. As we prepare for year two, if you are in a rural community or you have knowledge of trauma education needs in some of our rural communities, we are asking that you let us know which of the courses we facilitate you need. So those courses are ATCN, ATLS, ENPC, RTTDC, or TNCC. And this will include instructor courses. We are adding instructor courses in year two. I would say that one of the things we've learned over the course of this first year is that we need more help coordinating these courses. Karen Hust has been leading the effort for us, but the foundation will be hiring someone to manage this particular initiative. The job is expected to start in late spring or perhaps even early summer. GCTE will be among the first to get the job posting when it opens. The position is grant funded. However, we plan to continue this initiative beyond the grant period, which runs through the end of 2026. So yes, it will start out as a grant funded position, but it may change over to something else beyond the end of the grant period. And that's it for the update. If you have any questions, please feel free to reach out to me.
And Cheryl, if you can just briefly tell everybody or remind us, because everybody might not be aware that we were very fortunate as an organization to receive this grant, which is aimed at supporting rural Georgia, the education money.
Mm-hmm.
So just basically how much it is, and as you've mentioned, it's a 3-year grant.
Yes. So the Rural Continuing Education Initiative is one that is funded by a grant, and the grant was awarded through the State Office of Rural Health, which is a division of the Georgia Department of Community Health. This is a 4-year grant, and the award is just under $1.2 million. So the grant, as Tracy referenced, is for the foundation's coordination of continuing education courses for rural communities around the state. And the grant itself just simply allows us to expand access to the courses by eliminating obstacles. And that's obstacles that have been associated with payment for books or travel expenses or other course costs. We being the Georgia Trauma Foundation, we provide the administrative work for this grant, but our partners, and among those, GCTE, they provide, or you all provide, I guess you would say, the instructive work. One of the things we had to guarantee that we would provide a minimum of 48 courses over the course of the 4 years, which, as I mentioned, by the end of year one, we'll probably have 17. So I think we will exceed that goal probably by a mile if things continue the way that they have for year one.
Thanks, Cheryl. And I appreciate your leadership in us obtaining this grant and overseeing it. You know, don't have the clinical background or the expertise, but you've worked real well to try to engage people and try to pull people together. And I think this is a big accomplishment for the foundation and for the state. And I appreciate your leadership on this.
Well, thank you for that, Tracy. And I appreciate the support of GCTE because we couldn't do it without you. And that's the good thing about the trauma system. We all support one another and we're working toward the same end. So it's great to be able to partner with each and every organization that we can to make these things happen.
Thanks.
Thank you.
Okay. Next up is our superstar, Gina.
Well, I don't know about that, but I at least have some good news to share. Hey guys, I know y'all have had a plethora of emails from me in the last few weeks, but at least I have some great news that the Arbormetrics platform is finally up and running, and the last group of users got access day before yesterday, I think. Finally, we had a little hiccup with this last group with the delay in their emails, but everybody in the state should have received their activation emails and have access to log on. And I think I've said to everybody, that that's exciting, but the journey has now just started with access to the platform. So we're still working out some kinks with the data. Actually was on a phone call with them today, working out some kinks with the 2023 data. So, but now that we have access and to the first part of the analytics, we can start digging into it. And I really need everybody's partnership when you look at your data. And if you see something that doesn't look right, to let me know. You can certainly shoot me an email. I've created a SurveyMonkey link that's in the resources section of the Arbormetrics, and you can click on that and send me a message in there, and I can look through it. But I'm really excited about the potential that we have to pull out data from that. So it's just beginning. So doing a lot of work with that right now, picking through the data that's in there, making sure the analytics look like what we want it to. What is the 2023 data, January through September, is loaded. And I believe I sent out emails, at least to the first two groups. And for the third group, I'll let them know too. The January through September data is loaded. You just have to go in and put in a custom date range to be able to see that data, your data in there for that. So it's exciting to see that more real-time data that we've been looking for that. I'm in the process of doing some data completeness reports on that January through September raw data from the central site for everyone as we prepare for looking at what we're going to do for risk adjustment for our data within Arbormetrics, because that's kind of the next step, is that we'll kind of build and talk about what we want to apply for risk adjustment in the platform. So we've got to make sure our data is complete from that standpoint. So I'm working on those scorecards. All the level 4s are done, part of the level 3s. And so I'm working through that right now. So you guys will be able to expect those scorecards from me on that data. The ESO updates for your registry. I sent out an email today to all the trauma program managers because that's just the easiest to do. We've got so many registrars and who to send it to. Did get an update today. You will be getting a update to your registry that is a national update that will allow you your downloads to TQIP and NTDB. You should be getting an email any day now from ESO about that update. The Georgia update, which will allow your downloads to the GQIP Central site, the OEMS&T image trend registry, and will include the updated fields, will come out probably mid-March. So they're hoping maybe a little bit sooner, but that's the timeline on that. So there will be 2 updates that you will get
Gina,
to your
when
registry.
you say new fields, are you talking about fields for this year's admission group or
Yes.
next year's?
Well, it was supposed to be for last year's, and the hiccup came. So
Right.
it's those 2 new organ donation fields. So
Okay.
luckily it will only apply to the death cohort. So we were hoping it would come out a little bit sooner because we know we don't like for our registrars to have to go back and do work.
Right.
but it will apply to the 2024 admissions, but the two new fields that are mandatory are only for this. It's the two new organ donation fields that we added.
Okay.
That are in the data dictionary. So.
Okay. And also, for you, those of you that are newer to GCTE, just to know, GQuip is kind of like our, or the Arbormetrics project that Gina is talking about is kind of like TQuip, but at a state level. So it's almost like giving us a place where we can put all our data in and work on quality initiatives, or compare the data, focus on things that matter to the state, but also do our own ways of risk adjusting it. And it'll be a little more timely than the TQuip data if you're at a level 1, 2, and now a 3, but we'll all be looking at the same stuff. And I want you to look at this as a collaborative thing. So when Gina says dashboards, don't think punitive, just say, she's helping you to look at your data in a different way, or maybe from somebody who's got more experience of looking at it. It depends on your background and why you look at it. So when I look at the data versus a registrar looks at the data, we're looking from different viewpoints, but we're all doing it to improve what we're reporting about the care, because our registry is like a concentrated little trauma EMR or electronic medical record, and we want to reflect what's actually going on at our facility. So, if there's some data problems or the care problems, and usually it's a little bit of both when you find things that don't compare well to what you're looking at. So it's really exciting that we could do this at a state level. You don't get this I think there's only less than 5 states that do this in the United States. And so this is really exciting because we're kind of cutting edge in doing this, but it's a lot of heavy lifting. So, as I mentioned before, Gina's a superstar. She'll probably be have to have higher strength reading glasses after doing all this work, because it is kind of tedious looking at all this stuff, but it'll really help us compare to one another, but actually try to move forward as a state in improving, the care we give, but also seeking reimbursement for that care, which is what Liz talked about in her part of trying to get more money to help support our efforts in what we do.
Right.
So thank you, Gina.
Right. And I know Stacy mentioned the data validation visits that are actually starting with the level 4 centers, and are going to be kind of driven by to kind of help them out and give them some resources to improve their registry and some tools to improve what they're doing. Their resources are oftentimes slim. They're wearing many hats. They're being the trauma program manager and the registrar, and sometimes other roles within the facility. So, and since we're including them in this project, it's we want everybody's data to be as good as we can, because that helps the output that we see in Arbormetrics.
That's
and
a great point.
to be good, and then we can make really good decisions about what we need to do within our system.
Thank you. Okay, if we could start with the subcommittee reports. Julie, I think you're gonna report for education.
I sure am. So hi, everybody. For our education subcommittee, we have a couple updates to activity. A couple of work groups that are active currently, the Trauma Program Manager Toolkit. They met, they're working on developing a draft outline with resources and goals. They are also working on an essential trauma nursing skills group. This one's really exciting because people are going to take resources from larger centers and make them useful to all centers. So it can be a way that, centers with a lot of resources can give back and provide resources to those that are looking for them. So we're excited about that project. Nothing, no issues or anything arose from our last meeting, which was this on February 6th. We have been discussing the need for a centralized sort of repository and calendar for statewide trauma information and class offerings. And we're hoping that, that discussion will be more robust, and potentially the Georgia Trauma Foundation website might be a good option. So that's kind of something that we've been discussing, how we can make that useful to look for in one place. And our next meeting will be March 5th. And that's it from us.
Thank you, Julie. And I wanted to mention Cheryl has been joining the Education Committee meetings, so we really appreciate her input. So whether we use Trauma Foundation or some centralized spot, and then also even if we could to feed in on what's going on at the RTACs, they have that information available at the regional level, but is there some way that could feed up to a state level so that you can see what's going on in the state? It sounds like a big project, and it would be, but it would really be helpful when you have a one-stop shop for what's going on in injury prevention, what's going on with, pre-hospital education, or education that, will serve the rural hospitals, or, say I've got somebody who needs to renew ATLS before a certain date. I could go to one place and say, who's got what scheduled when. So that's something that we're working on. Thank you for that report, Julie.
My pleasure.
Okay, Kelly.
Can you hear me? Can you hear me?
Yes.
Okay. The pediatric subcommittee finished the SIPA tip sheet, and it went out to Georgia centers. There were no additional requests for any more in-depth education. So if you're sitting there and feel like your center would like some more in-depth education on SIPA, we'll be more than happy to work with you on that.
And Kelly, would you just explain again what SIPA stands for?
Sure. It's the Shock Index Pediatric Adjusted Score. So it's like a fifth vital sign, and we're hoping that the whole state of Georgia, when you're giving report on a pediatric patient, just like you would give shock index on an adult patient, we're hoping that we can start tracking and trending and following SIPA scores on patients. It's a good indicator, just like in adults, of when to maybe start blood. But the main goal of this project was to make sure that a pediatric patient wasn't put in the back of an ambulance without blood, especially on a long transport, if the center, the transferring center has already started to see a climbing SIPA score. So that's our goal of the project. I know the state, in coordination with the education subcommittee, was looking at pediatric transfers. And so we're trying to collaborate with the education subcommittee to see if we can create an inter-facility transfer toolkit. There was one created many years ago. It's much outdated, and we inquired on multiple listservs about any state that might have a pediatric transfer toolkit, and 100% of the answers said no, no one has one, but everybody wants one. So it might be that everybody's looking to the state of Georgia to produce a pediatric transfer toolkit, and then it sounds like they would like to adopt it. Let's see. CHOA, both Eggleston and Scottish Rite got accepted into a large whole blood study. It's a national study called the MADIC-2 study. We are going to be starting, it's a 4-armed study in September. September or October. We have a lot of meetings to get that started, but I think it's going to be exciting for the state of Georgia for CHOA to, start showing that whole blood can be used in pediatric patients. And it'll certainly, if the study goes well, make MTP at your center for kids a lot easier. So more to come on that. We'll keep everybody posted about that study, and definitely be in touch with EMS and about the use of whole blood in peds. We get a lot of questions from EMS whether or not we're using it yet. So starting in September or October, we will be. And then we're just working closely still with the Peds Ready committee to assist in any education when appropriate. So if any center has any gaps in their pediatric readiness, please reach out and we'd love to help you.
Thanks, Kelly. Any questions? Okay, process improvement, Rama, Ashley.
Let's see. I guess is Rama on the call? I guess she is. Can you hear me?
I can hear you. Is this Alicia?
This is
Ashley?
Ashley.
Yeah.
Okay. So Rama and we recently got together and, oh, is Rama on the call? No? Okay. Anyway, so we just recently got together. We're kind of just working out some details, working on new meeting dates, just trying to get kind of, I guess you could say, revamp, and in addition to what we're already doing, which is a lot of discussion with time to definitive care, transfer feedback, and EMS feedback. So we're currently working on getting some established dates throughout the year to continue having our PI subcommittee meetings. And we have just recently discussed some different topics that we would like to talk about at our meetings, in addition to time to definitive care. So it's a work in progress, and we're early on into this process. And that's really all I have right now.
Okay, thank you, Ashley, for jumping in, and I want to welcome you. Karen Hust and Rama were co-chairing this committee, and Karen has retired, and so Rama has stepped up, and she's going to be continuing to co-chair, but so Rama's at a level 2 in Atlanta, and Ashley's at a level 3 in Cordele, Georgia at CRISP. So I like the fact that we've got different level centers. And last year we were working on, and will continue, as Ashley alluded to, about time to definitive care. We were looking at some literature, doing some literature search for adult and pediatric, and this is where Kelly had helped us. What are best practices for transfer feedback and for just transfer. And so as we get restarted with our meeting dates and stuff, we'll have some summary of that information too. So Ashley, thank you for stepping up and agreeing to serve with us. And I encourage everybody, it's not just for level 1s and 2s. We want all levels to participate. It just is a refreshing look at how to think about things and how to look at things. And so I look for a lot of exciting stuff to come out of this group in the next year.
Yes, absolutely. Thank you, Tracy.
Okay, Colleen, take it away with the registry.
Can you hear me? Can y'all hear me?
Yes, ma'am.
Awesome. Well, we met the last week of January, and the 2008 AIS course is being held at Gypstick and Forsyth on 2/29 and 3/1. The CAISS certification test will use this dictionary and course manual until 2026. So that's why we opted to do that course. The GQuip data dictionary was sent out to everyone. And as Marie stated, the hospitals are in the process of downloading to the central site and GQuip. And you can now find the registry subcommittee PowerPoint on Basecamp. And I believe Gina will give you a login for that. I don't know how many logins. I think it might be one per center or something like that. And our next meeting is in April. And that's all I got.
Thanks, Colleen. And I wanted to congratulate you at becoming certified in AIS coding last year.
Oh,
and
thank you.
We've had quite a few that have stepped up and done that. So that is a new standard in the 22 book, in the gray book. It can be done. Colleen's got a lot of years experience, but we've got some people who have passed with only a couple of years experience. So a lot of it is just from what I've heard people say, and Colleen will probably agree, is you got to read the little text boxes.
And use your course manual. A lot of it is off that course manual.
Yes.
Yeah, hey, this is Gina. The Basecamp access for all the registry PowerPoints, we decided just to give to the trauma program managers because that was easy. And I just sent out all that access. So they'll get emails to access that folder for that, because it sounds like typically those resources they were wanting for when they would have their site visits and stuff to be able to show some of that. So it was easiest. So registrars, if you're wanting those PowerPoints either for reference or something like that, you can ask your trauma program manager to get those off the Basecamp site for you.
Thanks, Gina. And so that standard she's referencing is where your center has to show that you're involved. That's one of the first standards we went over last year, having regional, state, national participation. So they're even looking to the registrars to prove that you take part in something outside your hospital. And so these state meetings that they have, registry meetings, is a good way to do that. So if you download that slide set, you've got that. Plus you learn a lot and you get continuing ed credits if you've got some kind of certification. So I really encourage you to do that and to keep with it up with your education ongoing. TPMs need to do that. PI coordinators, they're looking at, how are you involved? Also your education. So just like your continued readiness for your center, you need to keep up with your education hours, whether it's just because you've got a certification or you're keeping up with it for your program and for your survey. So, always working on collecting that stuff. So thanks, Gina, and thanks, Colleen. Crystal?
Yes, I just want to make a point. Kelly Roker, I had shared a link with you in the chat box. I didn't know if your team had had a chance to look at that or if it was even helpful. I just was familiar with that resource being present there. So there's an interfacility transfer toolbox for pediatrics that the EIIC puts out. So there's also a disaster preparedness one as well. And I know several Georgia physicians participated in developing and reviewing that. So that may be helpful for teams as well. In terms of injury prevention and outreach, we did another Stop the Bleed webinar blitz since we last met, and just inside of 3 days, we did about 500 people. So the webinars do still tend to be popular. We get about 1,000 folks at the beginning of the school year, but that's over the course of several weeks. Whereas in this case, we just do 3 days of webinars, or one week, 3 days of offerings. So it turns out really nice. Thank you for everybody that participated in that. Certainly a team effort. And we actually do have other people that are coordinating those courses too, as many of you well know, because many of us are involved in in-person Stop the Bleed course delivery. So if anybody is looking to do a for the public community offering in the near future, and you would like to perhaps message out to anybody in your immediate area that went through the webinar and may still be involved or in need rather of a hands-on skills check, please let me know. I try to make sure that I'm connecting if there's a large group of any one school or school system. I try to make sure that I'm connecting them with instructors or that they have in-house infrastructure to be able to get those folks checked off. So again, thank you for those of you that are on our Stop the Bleed instructor list and available for volunteer Stop the Bleed referrals. We really appreciate that. Didn't have a chance to look to see if Emily Brown is in the room, but I want to congratulate her. We did a drawing for those of you that have been recruiting other instructors, and we've just been dropping your name in the hat, and she actually won our recruitment prize for this last recruitment drive we did for Stop the Bleed instructors and volunteers. So thank you, Emily, for that. In terms of bingo size, many of you are still doing that. We did learn that when our licensure transitioned over this for the second year cycle, that the area agencies on aging went ahead and purchased that again this year. That too was led by the Middle Georgia Regional Commission. They purchased the renewed licenses, but when that license renews, so must our training. So if you trained in bingo size in 2023, you're good. You don't have to renew again. But for those of us that trained a little earlier, our renewal is due. Don't do anything particularly special right yet. I'm going to be reaching out to all of y'all to see what your renewal needs are. It's very inexpensive in terms of renewal, but we do have a couple slots available. So you may be able to renew without any purchasing issues at all. The other thing is if you have needs in regards to bingo size, if you have needs in regards to the Georgia Stay Safe, which is our gun safety initiative, things like that. You know, I don't really have a lot of bandwidth to be able to mail resources out. Some of y'all have seen I met Carrie at Lynn's place last week, and you know you have to bring your pickup truck because we try to load you down with as much stuff as we can. If you have needs, I would like to maybe during the spring meetings, those of you that need a truckload, me bring my truckload. I know Lynn helped with that in August. That seems to work best for us versus versus trying to mail stuff. So just let us know if you have needs for resources that we have. I want to thank Emily Burnside with Memorial Health in Savannah for organizing our ATV safety webinar that we did for National Injury Prevention Day. I want to thank all of y'all for helping make sure that the word got out about that webinar. It was a great trauma after hours event. And I've been really watching a lot of y'all in terms of your social media postings, and you've been doing some great stuff centered around teen driving safety and National Injury Prevention Day and fall prevention. Keep up the good work. Do know that frequently, like if Liz or somebody is asking me to kind of compile some Georgia activities, you know, I may reach out to y'all too, but one of the key ways that I'm able to get pictures is I do go on social media and do hashtag prevent trauma. That's my easy way to search different Georgia facilities. That is our kind of our hashtag that we use. So if you're doing a prevention and outreach thing and you would like us to be able to kind of find it and pull it, please use hashtag prevent trauma. Or if you're doing something specific to Stop the Bleed, if you could use Stop the Bleed Georgia, all spelled out, hashtag Stop the Bleed Georgia. That enables us to be able to find those events, and so that any reports that we do are representative of everybody's efforts. And I think that's all I have. Are there any questions? Okay, well, we do have some spring webinars planned for April, and of course we'll do at least one day, perhaps 2 days of Stop the Bleed webinars in May. If anybody wants to join in those efforts, we would be glad to have you.
Thanks, Crystal. I'm just entering a link in the chat box. There was a webinar recently talking about a deeper dive into the new ACS standards by Trauma System News. It was a really pretty good webinar. And they have it subtitled "A Closer Look at New American College of Surgeon Requirements for Documentation, Specialty Coverage, PEDS, Level 3s, and more." So go to this link and it's recorded and you can watch it on demand. I believe they had a surveyor that was giving some feedback on some of the newer or more recent surveys that they had, just in the last quarter of this year, where they're using the new standards. Does anybody, has anybody seen this webinar and want to comment on it, or anybody who's had a recent survey want to share with us?
Hey Tracy, this is Melissa at Atrium Health Floyd. Can you hear me?
I sure can.
I was just going to comment. We actually did watch the webinar. I felt like it was very beneficial and informative. It does cover level 1, 2s, and 3 centers, and I would recommend those who have surveys coming up or in the next couple of years to actually go in and just watch, what pertains to their center, because I thought it was really good.
Thanks, Melissa. I think Josie had mentioned that. She does PI for us, and one of the things that she mentioned to me that kind of goes along with something I've said, and that the slide that Liz shared is some of the newer standards, where they want to show that you have coverage depending on your trauma program level, but you have coverage by certain specialty of physicians. So they want to see schedules, and they want to, so like call schedules, and they'll want to see like all the call schedules for your data year, and that's 12 months of schedules. And so she recommended going ahead and look at those standards, and if they apply to you, you should go ahead and be collecting those proactively, so you're not scrambling at the last minute to get it, or whether it's backup call schedules or whatever that you need. So I thought that was a really good tip, because we were anticipating and started like 12 to 18 months before our survey getting ready, and we were still kind of scrambling. And so there's really no downtime, as Liz showed you. You have your survey. We had our survey last year. We got this year to get ready. Next year is our data year, so you just never can let down. And that's why I like to review these standards. If people have experience with different standards as far as documentation or how things come back, just like Colleen shared about them uploading the slide set so you can show that your registrars are involved in regional or national or state things. Just anything, when you do that, we make the state stronger because we're more prepared for what the expectations are, but that makes our centers better. We give better care, and we keep our staff more attuned to what is expected and what we can do to make our programs better.
Tracy, this is Pam.
Hey, Pam.
I am actually submitting my PRQ tomorrow. So
Okay.
And our survey is in 46 days, not that I'm counting, but I can tell you the PRQ is a beast we thought it was a beast under the Orange Book. It is probably 4 times the work. So everything that you used to submit your document section, you are now submitting with your PRQ. So you have to submit all of those schedules, and we had to get 12 months of schedules. for every single surgical subspecialty. And if you don't have a centralized call center, it can be a nightmare. So I would really encourage people to start, once you get access to that PRQ, start looking for what they want in terms of evidence, because there are a ton of attachments. The PRQ by itself without attachments for us is about 90 pages if we put it in PDF form, and there's probably at least 150 attachments. So it is truly a lot of work.
And Pam, I saw that in my survey last year was under the Orange Book, but just this new virtual. And so I think going forward, are you going to have in-person surveyors for the survey part, or is it going to be virtual?
No, since we are a re-verification, it is virtual. I hear they're doing it in person for new verifications, but if you're a resurvey, they're doing it virtual.
Okay, thank you for that clarification. But that's the other thing you have to think about. And Pam, to Pam's point, and Pam, introduce yourself for those that don't know you or are new to our group.
Sure, I am the Vice President of Trauma at Grady, and you may have known me in my previous role. I was the Director of Trauma at AMC, and when we found out the day before our survey, we were closing. So I'm having a little PTSD with getting ready for survey. And then I was actually in Memphis for 10 months in between jobs. So I've been around a little bit in the last couple of years, but I lead trauma here at Grady.
Thank you. But as Pam mentioned, so she's got to have these 12 months of all these different specialty schedules. She's got to have it already saved in a PDF format like they want and send it in now 45 days before the survey.
Yeah.
So you're really backing up. You got to have all this documentation together before the survey. So then you got to back up. Oh, how long is it going to take me to gather stuff? So, take it from PTSD Pam. Hopefully you're not too bad. You just
it's all good.
Yeah. But it's always that continued readiness. So be looking at those standards. I'm always, I've been through them, but every time I read them, I'll catch these little things that you don't see or you didn't realize was there. The latest thing we've been working on is disaster preparedness and multi-casualty incidents. So fortunately, we've got Crystal at our facility, and she's a go-getter, and Region 5 has done a lot of work on that. But now we're trying to polish and what we do, but there's some new things that you have to have if you're level 1 that you have to have in your disaster plan or MCI plan about orthopedics. So that's new. And then also like just making sure that things have been followed up. So like we're looking at preparedness with our blood bank, and some facilities, when you get to be a level 1, sometimes they use it enough. They might have a refrigerator in the trauma bay. We don't. So you got to look at, well, how can we shorten the time to give blood if that's what's needed? So you look at those necessary or those precious resources. So, I challenge the TPMs and the PI people to go through and read those standards, whether they just, if you're going to concentrate on PI or what you're going to concentrate on, but go through it. And the PRQ document with the attachments, I've emailed to Gabby. So when she finishes her notes, Gabby, if you will send that PRQ out with the minutes, if it applies to you, look at it. But I'm looking at the standards now, and as we read those standards about radiology, it says, well, what do you have to show me that you're complying? Well, it looks very innocuous. It looks very genteel what they're asking for. But then if you look at the PRQ, what they ask for in attachments or other things, they get really specific, and it's not a light load. It's some heavy lifting sometimes to pull that together. Yeah. So if it applies to you, look at it and start getting prepared. So I've started putting some of our information together, whether it's PRQ and standards by specialty. So I started for my facility doing this in neurosurgery, putting that together. As you saw, radiology, there's 5 standards, but it's sprinkled across the book. It's not all right together. So you've got to look through there. And then also I've put together ortho.
Well, and Tracy, what I did is I actually created folders in Teams. There's a folder for each standard.
Yes.
And then everything that applies to that standard goes into that folder. And then we used a color scheme to show, when is it ready for my TMD to look at? When is it ready to upload? When is it? I have different colors so that we know exactly what was going on with each standard. And I'm happy to share that system if anybody wants further. And I'll have much more bandwidth to talk about this after March 27th.
Okay, so
and
there
I'm
you
happy
got
to be
it.
a resource.
Okay, so and Pam's in the contact list that Marie distributes, and then I think you've gotten to where you're sending it to the TPMs. They can forward it, but contact Pam after March 27th, and she can help you out. Any of us, just give us some time to get back with you, but it's all about, as we learn things, then we can help each other be stronger and have better programs. Does anybody else want to share anything? Does anybody else have an upcoming survey?
Yeah, I believe Kettystone is the week before us.
Oh, okay.
Yes, we are the week before, and the PRQ, I will reiterate everything Pam says. It is a very heavy lift. So we are looking forward to March 22nd, when we can all take a deep breath again.
Okay, guys. Well, I can use that infamous phrase. If there's no other business or nobody has anything else to add, we can give you 32 minutes back to your day. Again, use the QR code to sign in. Don't count on it getting picked up in the chat. Gabby's really good and she's trying to be thorough, but we got a lot of people, over 120 people on this call. And so we want to make sure you get credit for your attendance. I appreciate the contribution and everybody's time. And I hope you have a wonderful weekend. Make sure that you have signed in. And we will talk to you at our next meeting, I believe in May. Thank you.